Hello everyone, Dr. Polinoida and students alike. My name is Harold Lee and we are Group I consisting of Nadim Basim, Nicole Chong, Zili Liao, Jason Yu and myself. Today we will be presenting our DEN 3 OPM clinical scenario on oral ulcerations. Our patient SA is a 47-year-old male whose primary concern is a gingival lesion which found to be mucous membrane pemphigoid upon biopsy, present on the right aspect of gingiva and peeling of oral mucosa which persisted for 12 months. According to his medical history, no abnormalities to the respiratory, cardiovascular, and gastrointestinal systems were detected. The patient is currently recovering alcoholic, gave up smoking 3 to 4 years ago, and is not taking any medications. Further investigations were carried out in the form of clinical examination. They revealed that the patient's weight is stable and he does not exhibit signs of anemia, jaundice, cyanosis, finger clubbing, ankle edema, or any other skin lesions. The examination of extraoral tissues provided no other significant findings, which included lymph nodes, swellings, skin lesions, lips, and nose.
Thank you, Harold. I'm Jason and I'll be discussing the differential diagnoses for our patient SA. The differential diagnostic procedure is a systematic method of identifying the cause of the patient's clinical presentations. It involves interpretation of the patient's history of signs and symptoms and other forms of data collection to formulate a list of all the likely diseases and conditions. An accurate and thorough diagnosis is imperative as it informs a treatment plan and improves treatment outcomes. Having reviewed the patient's medical history and the results of special tests, a differential diagnosis could be established and categorized as hereditary, infectious, autoimmune, and malignant lesions. Epidermolysis bullosa is a rare condition which can manifest as intraoral ulcers. It is a blistering disease of the skin and mucosa that is mostly hereditary, and depending on its severity, may even be fatal. Although this is an unlikely diagnosis, our patient does present with characteristic clinical signs such as ulcers and desquamative gingivitis. Necrotizing ulcerative gingivitis, shortened to NUG, is a distinct type of gingival disease that can cause significant periodontal tissue damage, pain, and a fetid odor. A complex of spirochete and fusiform bacteria are thought to be responsible, as well as a variety of host factors. Our patient is a previous tobacco user, which predisposes them to NUG. Present with large areas of erythema and edema limited to the marginal gingivae and incidental papillae and without any systemic signs. There is no grey pseudomembranous slough typical of NUG, but lesions can be denuded of the surface pseudomembrane, which exposes a red, shiny, and hemorrhagic appearing gingiva as seen in our case. Several autoimmune disorders coincide with the patient's clinical signs. Biopsy of the gingival lesions has indicated mucous membrane pemphigoid, shortened to MMP. It is an autoimmune, subepithelial, blistering, and ulcerative mucous membrane disorder where antibodies are directed against antigens in the basement membrane. This results in separation between the epithelium and the underlying connective tissue, leading to formation of lesions after minimal trauma, including desquamative gingivitis and ulcerations. A very similar condition to MMP is pemphigus vulgaris. It is a painful autoimmune disease resulting in loss of intraepithelial adherence and formation of blisters and ulcers. Its pathogenesis involves autoantibodies which are directed against certain proteins, leading to loss of cellular adhesion. In addition to being an autoimmune disease, pemphigus may develop in association with trauma, drugs such as catropir and penicillamine, and internal malignancies. Similar to MMP, pemphigus lesions can present intraorally as ulcers and desquamative gingivitis. Another type of pemphigus that involves the oral mucosa is paraneoplastic pemphigus. It is a life-threatening, autoimmune, mucocutaneous blistering disease associated with a malignancy, particularly lymphoproliferative neoplasms. Its pathogenesis is similar to that of pemphigus vulgaris, except that the plaquing proteins are targeted as well. It has been hypothesized that the antigens associated with the tumor triggers the autoimmune response. However, the exact triggering event causing antibody formation is unknown. Clinically, the disease manifests as flaccid mucosal bullae, much like pemphigus vulgaris, together with extensive erythema. Lichen planus is an autoimmune disease that affects cutaneous and mucosal tissues. The patient's age group at 43 years puts them at higher risk of developing oral lichen planus. In addition, generalized red skin lesions periorally and desquamative gingivitis are both possible signs of lichen planus. Lichenoid reactions produce lesions that resemble oral lichen planus. One of its subtypes is lichenoid dysplasia, which is a dysplastic lesion with lichenoid appearance clinically. Another subtype is oral lichenoid lesions of graft versus host, which occurs following a transplant. Lastly, the two most common types are oral lichenoid contact lesions, where there is a topographic relationship to a causative agent, and oral lichenoid drug lesions, which are induced by certain medications. In this case, the presence of several amalgam restorations may be a potential causative agent for contact lesions. The only way to confirm this is to place a barrier around the suspected amalgam restoration, wait for the lesion to heal, then remove the barrier and see the lesion return. To exclude drug lesions, we must take a thorough history of the patient's medications, including NSAIDs, thiazine diuretics, penicillamine, ACE inhibitors, and oral hypoglycemic agents. Lupus erythematosus is a group of autoimmune diseases that can affect multiple organ systems. It is generally classified into two types, the discoid form only affecting the skin and mucosa, while the systemic form can cause multi-organ damage. Both can have oral and mucosal lesions, which frequently appear lichenoid and resemble leukoplakia or painful ulcers and erosions. Lupus is thought to be influenced by gene polymorphisms, but the degree to which they influence the disease is unknown. Lastly are ulcerations that arise due to an underlying malignancy, which could be due to a primary tumour or metastases from distant sites. Primary malignancies include oral mucosal squamous cell carcinoma, Kaposi sarcoma, lymphomas, angiocarcinomas, and salivary gland tumours. It is of utmost importance that this diagnosis be included for any ulcers of the mouth without an identified cause, particularly if they are non-healing and persistent. It should be noted that there is no prescribed form for malignant lesions and can even look relatively normal without any indurations or the rolled edges or granular flaws.
Thank you, Jason. My name is Dardine, and I will proceed to discuss some of the special tests we might undergo for a more definitive diagnosis of the patient's condition. Diagnosis of MMP can be challenging for the operator and requires thorough evaluation of the patient's complaint, history, and clinical features, both oral and extraoral. These presentations in SA have been discussed by Harold. Using this information, we as the operators can begin to determine the appropriate differential diagnoses for MMP. These include epidermolysis bullosa, lichen planus, lichenoid reaction, pemphigus, pemphigoid, systemic lupus erythematosus, malignancy, oral candidiasis, and necrotizing ulcerative gingivitis. However, in order to progress from these differential diagnoses to a definitive one such as MMP, special tests and further investigations need to be undertaken. The results are then compiled and added to existing information to enhance treatment and management for the patient. One such example is a biopsy. A biopsy refers to a sample of tissue taken from the body to examine it more closely. The biopsy is presented for histopathological examination, and often multiple biopsies are necessary from the edge of blistered or ulcerated tissue. Immunostaining is essential and usually shows subepithelial vesiculation with linear deposits of IgG, IgA antibodies, and sometimes C3 proteins at the basement membrane zone. These are the antibodies involved in the autoimmune reaction of MMP. Serum antibodies to epithelial basement membrane may be detected in few patients. A biopsy is absolutely necessary for the definitive diagnosis of MMP. Another special test is a blood sample. A blood sample may be useful to test for skin antibiotics through the use of indirect immunofluorescence. This is less important than a biopsy, but still beneficial for the operator. CT scans or barium swallows can be used to determine the state of the upper airway or esophagus, which are often involved in MMP clinical manifestations. Again, whilst this can be used for confirmation as well as to understand the severity of the disease. This cannot be used alone. However, it is used in conjunction with a biopsy for confirmed diagnosis. In addition, it contributes to the overall management of the patient. Nikolsky's sign is an investigative examination where the lesion is gently rubbed. A positive Nikolsky sign would be observed as the top layers of the skin slipping away from the lower layers. Usually, a blister forms within minutes. These are some of the special tests that we might undertake in order to further investigate the case of SA. I will now pass on to Nicole and Lily, who will discuss the overall management for the patient.
Thank you, Nadine. Nicole and I will be covering the management of all the differential diagnoses mentioned by both Nadine and Jason. Specifically, I will be covering the management of mucous membrane pemphigoid, pemphigus, and systemic lupus erythematosus. It is important to determine whether pemphigoid is localized or generalized. It is generally regarded as a steroid-responsive disease, and systemic steroids may be indicated for generalized pemphigoid. However, this line of therapy is rarely necessary when only oral lesions are present, and can be replaced by high-concentration local steroids. General management of these patients also include an ophthalmological opinion for the diagnosis of cicatricial pemphigoid. For localized management in patients presenting with persistent and multiple lesions, triamcinolone can be used in varying amounts. A chlorotetracycline mouthwash is used as a vehicle, and a strict regime of mouthwash measurement should be emphasized. In patients with less active but still persistent orobula, a less aggressive approach to local steroid therapy may be adopted. Baxdrosol has been found particularly successful in resolving soft palate lesions, which are difficult to reach by other means. Candidiasis may occur, which may be treated by antifungals. A recent study done via intralesional injection of corticosteroid drugs directly into oral lesions has found a success rate of 75%. This method provides a high localized concentration of corticosteroids in the tissues while minimizing the systemic effects. The disadvantage of this method is that it only provides remission but does not prevent recurrence of pemphigoidal lesions. Care must be taken to prevent injecting into ulcerated areas, which are regarded as probably infected. After treatment, patients can be instructed to apply a topical ointment containing triamcinolone acetonide, such as Kenalog, to the maintenance of oral hygiene in patients with multiple painful bulla may require professional help and oral hygiene advice. In edentulous patients, denture problems may be considerable. However, the patients with these more aggressive forms of oral pemphigoid seem to show a remarkable degree of adaptation to the problem. Besides, the use of antiseptic or antibiotic mouthwashes may be valuable in reducing discomfort when ruptured bulla. Pemphigus vulgaris and paraneoplastic pemphigus are the two categories of pemphigus that manifest as oral disease. The first step in management would be to correctly diagnose the category of the condition, which could be done in various ways. For instance, tissue biopsy, indirect immunofluorescence, and enzyme-linked immunosorbent assay. This slide explains direct immunofluorescence and indirect immunofluorescence in greater detail. Pause here if you wish to have a better look at the image. The primary goal of treatment includes minimizing disease burden and improving quality of life. In most patients, this clinically translates into the absence of blistering. Pharmacologic treatments for pemphigus vulgaris have been found to be effective. Topical agents may be useful for palliative treatment. Topical anesthetic rinses are often effective for temporary relief, whereas high-potency topical corticosteroids may be used alone or in conjunction with systemic treatment. Topical tacrolimus has demonstrated some benefit in treating recalcitrant lesions. Intralesional corticosteroid injections can also be used, but has been associated with scarring and or mucosal atrophy. Systemic corticosteroids are the first-line treatment. As the corticosteroids are tapered over months, steroid-sparing therapies including rituximab are initiated. Rituximab has become a first-line treatment of pemphigus and a safer alternative to steroids in recent years. Because patients usually require a prolonged course of corticosteroids, more than 3 months, the prevention of glucocorticoid-induced osteoporosis must be considered. Bisphosphonates, along with calcium and vitamin D, are the mainstays of prevention. Patients on chronic glucocorticoids should be monitored for adrenal insufficiency, infections, hypertension, steroid myopathy, and gastrointestinal ulcers. Evaluated further and attempts undertaken to taper the dose of glucocorticoids and or add steroid-sparing therapies should they demonstrate any symptoms. Pharmacologic treatment for paraneoplastic pemphigus includes prednisolone, cyclosporine, cyclophosphamide, and other examples of less common treatments are intravenous immunoglobulins, and rituximab. Moving on to the non-pharmacologic strategies, the recommended treatment of cutaneous erosions includes cleansing with antibacterial soap, followed by bandaging with non-stick potassium gauzes. Patients should avoid aggressive oral hygiene practices when symptomatic due to increased risk of pain and bleeding. Gentle oral hygiene measures may consist of saline rinses and should be discussed with your oral health care provider. An international survey has revealed poor agreement between countries regarding the treatment of SLE. Guidance on the management of SLE in Australia is limited and dated. However, several original research articles provided summaries of patient treatment, primarily hydrochloroquine, corticosteroids, azathioprine, NSAIDs, methotrexate, and cyclophosphamide. In these next 3 slides, I have added summaries of treatment of SLE from different articles. Pause if you wish to read these findings. In 2016, EULA used an evidence-based approach to develop recommendations addressing SLE management. Treatment differs depending on disease manifestations. The treatment of non-major organ involvement are listed and generally used in severe cases. Despite the widespread use of immunosuppressive agents, there are only few randomized controlled trials with variable outcome criteria demonstrating their efficacy. Therefore, EULA recommend judicious use of these agents considering the potential harm associated with each drug. Adjunctive therapy includes treatment of skin lesions, atherosclerosis, and bone mass loss. In a double-blind intra-individual comparative study, sunscreens prevent development of skin lesions following photoprovocation. In patients receiving long-term glucocorticoid therapy, calcium and vitamin D may protect from bone mass loss. 2 studies have demonstrated benefits of bisphosphonates in a mixed population. Despite the lack of SLE-specific literature, weight control, physical exercise, smoking cessation are recommended, especially for patients with increased cardiovascular risk. Statins and antihypertensives should. Antiphospholipid antibodies are commonly encountered and associated with increased risk of thromboocclusive incidents. In such patients, low-dose aspirin is recommended for primary prevention of thrombosis and pregnancy loss. Lupus nephritis treatment often consists of intensive immunosuppressive therapy, followed by less intensive maintenance therapy. Initial management of moderate to severe flares requires induction therapy with immunosuppressive agents, which usually prevent loss of renal function. Thank you. I'll now pass on to Nicole.
Thank you, Lily. Let us now start with the management of lichen planus. There is no curative treatment. Patients should be advised to reduce smoking and alcohol and consume a nutritious diet to help reduce oral cancer risk. Treatment of erosive and atrophic lesions with topical steroids, which can convert them to reticular lesions, may also reduce the risk of oral cancer. Long-term follow-up is necessary due to the small risk of malignant transformation. Lesions should be reviewed monthly for symptom alleviation, and active treatment continued until symptoms are controlled. The elimination of erythema and ulceration leaving residual asymptomatic reticular or papillary lesions may be considered an endpoint of current therapy. Patients should then be reviewed at least 6 monthly and lesions rebiopsied as required. Symptom exacerbation or lesion change should incite a visit to a professional. According to Ismail, Kumar, and Zain, good oral hygiene as well as minimization of exacerbating factors such as mechanical trauma can enhance healing and lessen symptoms. There have, over the years, been many treatments available, especially for symptomatic cases. These tables are an overview of a number of treatment modalities used for oral lichen planus from 1978 to 2006. As can be seen, there are surgical treatments, removal of causative agents, such as amalgam, pharmacological non-surgical treatments. Please pause the video if you wish for a closer look. Treatment with cyclosporin and other drugs has been reported. A recent Cochrane review found only weak evidence for the superiority of cyclosporin, retinoids, steroids, and phototherapy interventions over placebo for palliation of symptomatic lichen planus, and concerns also include side effects and lesion recurrence following withdrawal. We advise, as according to Australian therapeutic guidelines, cessation of factors such as smoking and alcohol that increase risk of neoplastic changes. Many patients are concerned about the possibilities of malignancy and contagion. Patient education may improve the outcomes of therapy and further reduce the risk of oral cancer. Let us now move on to lichenoid reactions. The removal of causative agents is a main treatment. More details are listed for the different types of lichenoid reactions on this slide. The aims of current therapy is to alleviate symptoms and reduce the risk of oral cancer. Medical treatment would therefore be restricted to atrophic, erosive, bullous, and symptomatic lesions only.
Corticosteroids are the mainstay of therapy because they dampen cell-mediated immune activity. An example is topical betamethasone dipropionate. Generalized oral lesions are often treated effectively with a steroid mouth rinse. Due to the general guideline of minimizing the frequency, amount, and duration of corticosteroid use, the ointment should only be used if symptomatic. Topical steroid use has fewer side effects compared to systemic, however, over-application can lead to adverse effects such as candidiasis. Topical steroids should not be used continuously for more than 3 weeks without specialist advice. If the lesions have not resolved after 3 weeks or a change in appearance occurs, the patient should seek specialist advice. The combination of systemic and topical therapy is often very effective. Generalized atrophic or erosive oral lesions that do not respond to topical therapy may be treated with a short course of systemic corticosteroids. Contraindications of corticosteroid preparations are listed. Because there is increasing evidence of Candida albicans superinfection with oral lichen planus, a smear should be taken periodically, and any candidal infection controlled with topical antimycotics, especially in high-risk groups such as xerostomics. Some patients should be managed prophylactically to prevent secondary candidal overgrowth. Now let us go through epidermolysis bullosa. Topical corticosteroids effectively control gingival lesions. Systemic steroids alone or in association with immunosuppressive agents and dapsone are the suggested treatments. Let us now move on to malignancy, the most common of which is oral mucosal squamous cell carcinoma. Scully and Felix advise that if a biopsy, which is mandatory for high-risk lesions in patients, confirms neoplastic changes, specialist referral should be immediate. The dentist should also assess for need of psychological assistance and recommend services such as counseling if required. The dilemma in managing potentially malignant lesions and field change has been of deciding which areas will progress to carcinoma. Specialist referral is indicated in any cases of doubt. A healthy diet and cessation of dangerous habits such as smoking should be strongly encouraged. Lesion removal is generally the best course of action. Chemo and radiotherapy will likely be prescribed, especially if metastases have occurred. Let us now talk about necrotizing ulcerative gingivitis. Immediate management includes gentle removal of plaque and necrotic debris under local anesthesia if necessary, local irrigation with chlorhexidine mouthwash or hydrogen peroxide solution, and oral hygiene instruction. Prescriptions considered include antibiotic therapy such as metronidazole, or if patient adherence is a concern, tinidazole, plus in all patients, chlorhexidine mouthwash until pain has abated. The patient will be reviewed in 2 to 3 days for oral hygiene instruction and periodontal examination. It is essential to remember that thorough local debridement is necessary in preventing recurrences once the acute stage has resolved. Antibiotic therapy alone, without debridement and improvement in oral hygiene, will lead to recurrence. In the immunocompromised, unresponsive, or very severe cases, prompt specialist referral is indicated. In the interim, phenoxymethylpenicillin or amoxicillin is indicated. Clindamycin might be substituted for patients allergic to penicillin. In conclusion, dental practitioners encounter numerous lesions in the oral cavity in day-to-day practice. Of these, ulcers constitute a significant proportion. As outlined by Harold, a comprehensive clinical examination and history taking are essential components for an accurate diagnosis. Subsequent to this, the differential diagnoses are established and special tests are required to determine a definitive diagnosis, as discussed by Jason and Nardin. Finally, once the diagnosis has been determined, an appropriate treatment plan can be established. To conclude, each of these steps should be carried out in a logical, systematic manner to ensure thoroughness and effectiveness. We as dental practitioners have the professional and civic responsibility to properly diagnose lesions and execute a good and effective treatment plan. Thank you for listening.